Hello and welcome to this pre-course video for the difficult vascular access in children. My name is Dr Gowdy and I'm an A&E Reg currently in the Ulster Hospital, and today we'll be chatting through the theory of ultrasound-guided IV access. This video is a theory around the ultrasound, a bit about the physics and how to successfully insert cannula under ultrasound, and will be used to complement the other videos within the course. Our objectives for this short video is really to become aware of ultrasound-guided cannulation and when to use it, how to specifically identify arteries versus veins on the ultrasound, and how to modify and interpret our image correctly, and then some top tips for success. So ultrasound-guided IV access is a get-out-of-jail-free card, okay, in adults. 1 in 3 inpatients in the hospital are regarded as difficult IV access. Obviously children with much smaller veins tend to be a lot harder as well, so the number for that could be even higher. So when should we do ultrasound-guided IV access and when should we not? So we should be thinking about it in patients that are known to have difficult IV access or have a predicted IV access score which is high, and also previous failed attempts. Contraindications to this would be sort of local infections in and around the site, burns, phlebitis, any fistulas, and any lymphedema. Okay, so any reason that you wouldn't put a normal cannula there, you probably shouldn't put an ultrasound-guided cannula there. So complications are similar to that of a normal cannula as well. Okay, so local infection, thrombophlebitis, extravasation, nerve injury, and arterial puncture. You may have seen some ultrasounds before, but you may have noticed there's 3 different types of probes on the ultrasound, and we're going to be interested in the linear probe. It is a high frequency probe and it is good for looking at superficial structures. The curvilinear is typically used for abdominal indications, and the phased array probe is used for cardiac indications and not be relevant for this course. If you could please note that on the linear probe there is this little line in the middle of the probe, and that will become useful later. So the ultrasound machine. Often turning on the ultrasound machine can be the hardest point, and if you're struggling to find the on button, typically it's hidden around the back. Once you've turned the machine on, you'll see a screen similar to this one where the circle is around the word probe. We're looking for that button. It might say transducers or exams or something similar, and we're going to hit that button and we're going to get a picture that looks a bit like this at the top, where there's the 3 pictures of the probes that we've just discussed, and you're going to pick the probe that looks like the linear one, the flat one. Below that you'll see that there is a subset of menus. Okay, this will let the machine know what you're looking for and will help modify the image to try and improve your success rate. So if you tick vascular for that, that will help. Here's a Sonocyte machine with something similar. You can see that there's the 3 pictures in the middle of the screen here. Again, we'll just pick the one that says the linear and then pick vascular or venous. So once we've selected our probe, you should get a screen that looks like this, okay, where it's flat along the top. And then we need to figure out which is left and which is right. So the easiest way to do that is gently put a bit of pressure on one side of the probe and look at the screen to see which is the left and which is the right. Do this gently as there are crystals in this probe, and if you push hard you might break them. The other thing to note is that all probes will have a marker, which is here just beside my finger, and that will correlate to a marker on the screen which I'm pointing out here. So if we put that marker to the same side, left will be left and right will be right. So typically we'll put this to the patient's right whenever doing vascular access, or our left. Setting up the machine. Okay, so this is the patient here, and this is us getting ready to do the cannulation. We can have AB is where we're going to put our ultrasound machine, and not at C. We want this as so that the line of sight for we're putting the cannula in and where the ultrasound machine are all in the same line of sight. So we're not looking backwards when we're doing it. Holding the probe. This is the way we're going to hold the probe. If you have your thumb facing towards you, holding it down near the shoulders of the probe, which are here, and then our fingers at the back with part of the hand resting onto the patient's skin or something, so that we get the extra tactile feel so that we're not slipping around. The ultrasound probe itself, okay, so this is a wallpaper scraper, and it's quite a useful thing to think of ultrasound as. So if you think of the probe as this handle and the beam as the blade, okay, so the beam comes out and it's extremely thin and it's a 2D picture, and it's up to us to utilize that 2D picture and make it into a 3D picture within our heads. So setting up the machine, you can see here this is just showing the depth. Okay, this is the same vein on the same patient with the same probe, and you can see by altering the depth you can make the resolution of the veins a lot better. Okay, so on the left hand side the depth is set at deep. The machine has to wait for all the beam to come back before it sends out another one, whereas on the right it only has to wait a shorter period of time before sending out a second beam, so the image becomes a lot more higher resolution, and additionally the structures become bigger, which makes our job easier. The other main control is gain, which is brightness. Again, this is the same vein and the same arm with the same machine and probe, and the picture on the left is too dark and the picture on the right is too bright, okay, because our needle is going to be white, so we don't want everything to be really white. So putting them together, we can see that the pictures on the left are not brilliant, or whenever we've optimized the depth and the gain, we should hopefully get a picture that looks at that on the right, and that is what we're aiming for. So, arteries versus veins. So the key thing with these is collapsibility. Veins will collapse with a small bit of pressure, where arteries will not. If you do put a lot of pressure on an artery, you will collapse it. Arteries tend to be more round, and they'll be roughly where you'd expect an artery to be going from basic anatomy. Additionally, we can use colour flow to detect an artery, whereas veins, you may not be able to detect the flow, as the flow may be too slow. It's important to note that whenever you're putting the probe on, you put the probe on with as little pressure as possible. Often whenever beginners are doing this, they say that they can't see any veins, but it's because they put too much pressure on the probe, and whenever they lift it up a wee bit, the veins will then become visible. Particular caution in interpreting arteries versus veins needs to be considered, particularly in this group of patients, so shocked patients. Pediatrics obviously very relevant for this course, and the elderly if you're practicing outside of pediatrics. The reasons here, shock is the blood pressure might not be high enough to accurately see the pulsation. In pediatrics, obviously the arteries can be quite small and the heart rate can be quite fast, so it might be difficult to determine it. And in the elderly, it can be quite difficult if their veins or their arteries are a bit more stenotic. So just caution with those, and if you're not sure whether it's not an artery or a vein, it's obviously best to avoid it. Okay, so this video will show us an arm here. Okay, you can see here is a pulsatile round area. Okay, this is an artery, and here is a vein. You can see it collapses with the pressure. Okay, but if you note at the start of the video, the artery did collapse whenever a lot of pressure was put onto it. Okay, but you'll still see that it is able to pulse through that. Putting Doppler flow through it. Okay, so Doppler works by detecting the direction of the flow. It does not detect if it's arterial or venous, and it works by changing in the frequency, similar to what you would hear if an ambulance was driving to you and then away. And it is controlled through this square box on the screen. So you can see this is my brachial artery, and you can see that the box is on that and it's pulsating, and then we move it over to a vein, and there is no flow here. Okay, so, and that's just because the venous flow isn't as fast. So you can see there a pulsating round object, artery, non-pulsating collapsing vein. So just to highlight that red does not mean artery. This is both the same artery. You can see here that it is lit up blue, and on the other side it's lit up red. And this is all to do with the direction of flow and what way the ultrasound probe is pointing. And remember this, the colour, what we expect to do with BART. Okay, so blue away and red towards. So if you point the ultrasound probe up towards the head, the flow of blood is towards the probe, so it should appear red. And if you point it distally towards the hand, the brachial artery should appear blue, as the blood flow will be away from the probe. I think think of our cannula a bit like a plane landing on a runway. We want the plane to run down the full length of the runway, is maximise the full length of it, rather than coming in at an angle and potentially crashing like this. So if we think of that in the same way of our cannula, look, if we go down, we maximise our chances, where if we come in at an angle, we're more likely to go through the side of the cannula like this. So in order to do that, we need to think of our ultrasound as a tool to find the runway. So on these next slides, you will see the blue box on the arm move up and down, which is the probe, and on the right you'll see a representation of the ultrasound screen with the black grey circle being the vein. You'll see that the ultrasound probe moves up and down, and that the vein will move on the screen, and I want you to have a think of where you would think that that vein roughly goes in that arm. That this vein moves from the left hand side of the screen to the right as the probe moves from distal to proximal, indicating that the vein is going to go from the ulnar side up to the radial side. So it's going in sort of in a plane like that. So then what we do is we give our probe a slight twist and move it along the line that we think that the vein is going in, and hopefully you will see that the vein stays in the middle of the screen or close to it. And if this does happen, then that shows that you have successfully found the path of that vein. So the other way that we can help find the direction of the vein, if we're struggling to find it with the other way, is by rotating the probe slowly 90 degrees, as you could see there on the arm. And what should happen if you keep the vein in the middle of the screen at all times is that the vein will start to open out. And once it's opened out fully across the screen, you can then look at your probe to see which direction the probe is going, in this case straight up and down the middle of the arm, and then you'll know that that vein goes in that direction, and then you can come back and then slide back into our transverse way. In order to do this, if you slip off and the vein is moving slightly to the left or right while you're twisting, don't panic, keep it at the angle it's at, but gently slide the probe left or right to get the vein back into the middle. So just one of our first top tips. So you can see the way that the ultrasound works, with the blue box being the probe again, and the red line being the ultrasound beam. The ultrasound beam reflects off the needle and goes in a direction, and it's the beam that comes back to the ultrasound probe that we will see. So you can see that on the left hand screen, if you have the probe vertical, that quite a lot of the beam will ping off and not go back to the probe, making the needle appear less bright on the screen. Whereas if we tilt the probe just slightly, we can see that most of that beam is going to come back to the probe and make that needle appear a bit brighter. It's important to note that this is just a gentle tilt, as if you tilt too much, you will start to come off the skin. And as you go deeper in the skin or in the subcutaneous tissues for the veins, this effect will get worse. So keeping things clean, okay? So we do not use this ultrasound jelly, which you may have seen hanging around some ultrasound probes. It is not going to be clean. We use specific ultrasound jelly, or jelly that we would use for PR examinations, so sterile lubrication. As long as it says sterile on it, it should be fine. And additionally, whenever you're starting, you can take a cannula dressing, and the see-through part of it you can put onto the probe, which will help keep it clean. Obviously, you will need to make sure that the probe is clean before starting, and clean the arm as well. So the way that I do it is that I get my alcohol wipe, clean the entire area of the arm that I might be interested in, and then put the jelly on. So So actually getting the needle into the vein. So what we're going to be looking for is bullseye. So here's a picture of a vein with a needle in the middle of it. The needle is the bright white bit, okay? At the minute we have no idea if that is the middle of the needle tip, which is the bit that we're interested in. It could be the tip, it could be the middle, or it could be any part of the needle. So some people use ultrasound just to find the veins and put the cannula in normally once they have a rough idea, or just put the cannula in under ultrasound and wait till they get flashback. These ways are maybe a bit better than just doing it blind, but they're not perfect. So we're going to chat about the meet and greet technique. Okay, there's a number of different names for this in the literature, but if you start to do this, you'll notice that you get a lot better, and the literature suggests that if you use this technique, you'll be about 30% better. So what is it? Okay, so we need to recognize that we can't see the tip unless we scan. So in order to do that, we need to make the needle tip disappear. So if you look at my arm, if that is the needle and here's the probe, as I scan down, you'll get white, nothing just at the edge. So it's that nothing bit that we're looking for, and that lets us know that it's the tip. So we're going to do that from the moment that the needle enters the skin. So in this diagram just highlights it within the vein. So you can see here that we've got our bullseye sign, that the probe is looking at the needle and the needle is in the vein as highlighted by this, but we're not sure if this is the tip. So in this case, we keep the needle perfectly still. We advance the probe just until the white disappears, and we're talking millimeters at a time here. The less movement, the more accurate you can be. At that point, then the probe stays perfectly still, and the needle advances into the plane of the probe, and then the needle stays still, and so on. Okay, and that way we can be sure that the needle progresses up the vein. Okay, a number of reasons for this. If you just get flashback, the plastic tip of the cannula might not be in the vein, it won't advance properly. Additionally, if you've put too much pressure onto the vein, and then when you lift the ultrasound probe off, the anatomy might spring up and the vein might go out the back of it. Whereas if we do this, it will force us to flatten out our angle and make sure more of the cannula is in the vein and make those less likely. Obviously there will be a happy medium. As the further you go in, the more likely you are to go through the back. So what if you do go through the vein? Okay, you can still save the day. Okay, so come back with the ultrasound probe until you get our bullseye sign. At that point, we'll reverse our needle, keeping the ultrasound probe perfectly still just until it disappears, and then we'll go back to our probe needle technique. Okay. So putting that together, what does that look like? This is a handy video from a butterfly probe which shows it in two planes. Unfortunately, not many places have these probes, but it's pretty useful to see. So on the bottom screen here, you'll see this is what we will be aiming for, probe needle, and you should see the needle coming in and out of view. But on the top screen is a longitudinal view where you'll see the cannula advance up the vein. Okay, and if you keep your eye on it, you'll see eventually that there's quite a lot of the cannula into the vein. So you'll see here that this needle keeps disappearing in and out of view. Okay, and that's just doing our probe needle, and up here it is marching up the vein. So you'll see in a second it'll pan back, and actually quite a lot of this cannula is in the vein, and that will really increase our chances of it staying in. Summary of what we've gone through today's talk. So we've chatted about the key things with the machine optimizing our depth and gain and what probe to pick. M mode, if you push that button on the machine, which we can show you on the day, or a centerline button, drops a line in the middle of the screen. This is quite handy as an extension of the line that we pointed out at the start of the talk. And if you get the line right on top of the vein, you know that that vein is right underneath that line in the middle of the screen. Use as little jelly as possible. Okay, obviously we need jelly for the ultrasound to work, but afterwards we've got to stick down the dressings to keep the cannula in place, and the more jelly you have, the more difficult this is. So make sure you don't pull out the cannula whenever you're getting rid of the jelly, and sometimes two dressings if it's particularly difficult is useful. So one the normal way and then one at 90 degrees. Use as big a cannula as you think you can get into that vein. Now obviously quite limited in pediatrics, and usually it would be very small cannulas, and small cannulas you will be able to do this technique with no problem, but the bigger cannulas will be easier for the ultrasound for you to find, so just keep that in mind. Preparation, so all the usual stuff, particularly focusing on where your machine is set and trying to get some helpers involved and explaining to the child and the parents what's going to happen, because we want to make our first attempt the best attempt at this. Superficial veins are preferable for the reason of the mirroring that we've chatted about already, and also the fact that if it's a superficial vein, we'll waste less of the cannula getting down to it, and more of the cannula can be in the vein, and that cannula is going to last a lot longer. A second person to help hold the skin taut for insertion, because you'll have one hand on the probe and one on the needle, and also this person can help look for flashback so that you don't need to take your eyes off the screen. Because if you take your eyes off the screen, you might find it tricky to find that needle again, and you might be back to square one. Hockey stick probes can be used as well, and you can invert the image, as sometimes where the pointer is, it can make it quite tricky to hold, but you can flip the image if you know how to do that in your settings. In particular, please stay away from veins that are near arteries until you're an expert. And becoming an expert, it's probably best to practice this skill on easier patients, okay? Because it's going to be quite tricky for you to get the one that nobody can get on your first attempt, and it might be a good idea for you to go to practice on some adults, as it will be easier in adults before you try on kids, but you hopefully shouldn't have any too big an issues. So that brings us to the end of today's talk. So thank you so much. We look forward to seeing you at the course. So thank you.